Thank you, Cha. Good morning, good afternoon, good evening to everyone. Since we have six speakers today, I will keep it quick and quickly hand over the floor to them. And it's exciting that we are having this first ever webinar this year, this Africa Asia Digital Health Exchange. And then we have speakers from both Africa as well as Asia. We will have those sharing, starting with the speakers from Africa, then followed by those from Asia here. I'll quickly introduce them, starting with Dr. Rayan. Dr. Rayan is a strategic digital health leader and architect of Kenya's National Digital Health Superhighway, having served as the inaugural head of division for digital health at Kenya's Ministry of Health, where he spearheaded the creation of country's groundbreaking Digital Health Act. He was one of the leaders who oversaw the scaling of ECHIS to serve millions of Kenyans through its adoption and use by more than 100,000 community health workers nationwide. The next speaker will be Derick. He is a digital health leader and is currently serving as Chief Programs Officer at Medic, based in Nairobi. He leads a global team of developers, project managers, and service designers delivering the community health toolkit to frontline workers in Africa and Asia. Derick is currently supporting the Kenya Ministry of Health in a world-leading initiative to digitize 107,000 plus community health promoters, ensuring that data-driven care reaches every household. Next speaker from Africa will be Dr. Job. He's a medical doctor and digital health professional with over a decade of experience in the public and private sectors. He's currently working on building Kenya's digital public infrastructure for health and advancing health information systems interoperability across Africa. Welcome, Dr. Job. And next will be our speakers from Asia, starting with Ms. Bala Rai. Ms. Bala Rai is a senior hospital nursing administrator and chief of nursing capacity building section at the Nursing and Social Security Division, Department of Health Services, Nepal. She has over 23 years of experience across clinical service delivery, academia, research, and government service. Her work focuses on strengthening nursing quality through guideline development, workforce capacity building, specialized nursing standards, community and school health programs, midwifery, and infection prevention and control. Welcome, Ms. Bala Rai. Dr. Nitin Bhandari will be the second speaker from our region. He is a public health physician and digital health practitioner. He currently serves as the program head for Asia and country lead for Nepal at Medic, where he supports federal, provincial, and national governments to design, deploy, and scale community health information systems as part of routine public health service delivery. His background spans clinical medicine, community medicine, health policy, digital public infrastructure, with a focus on maternal and child health, community health workers, and system sustainability. Welcome, Dr. Nitin. And our third speaker from the region is Mr. Prajwol Shrestha. He is a product and technology advocate with 12 years of experience developing healthcare and cloud platforms at scale. His healthcare IT background includes 5 years in US private healthcare analytics, data compliance, and standards, and 4 years supporting public health systems in Nepal, Kenya, and Uganda. He has expertise in the community healthcare toolkit, fire interoperability, and data analytics using Python, SQL, AWS, and Apache Superset. So we have all the six speakers online with us, and I would like to hand over the floor to the African speakers, starting with Dr. Rayan. Over to you, Dr. Rayan. Thank you very much.
Thank you very much, Dr. Jai. So our presentation is titled The Kenya Ichis Narrative, Deep Partnership for Attaining Scale. And here we have representation from Medic, Safaricom, and Chairi, all of us being active members of Helena. One of the areas where this conversation is anchored is in the countries. Currently, we have a government who has given us very good political will in terms of implementing a lot of systems change for the sake of achieving the delivery of universal healthcare for all. This is the target for Kenya. So there are a lot of there's a lot of changes happening in the finance area, in the HRH area, and also the pharmacy and non-pharmacy, pharmacy and non-pharmaceutical region. And this is where, for these things to work, digital health was identified as one of the anchoring ones. There's been also a lot of work which was done in terms of the legislative framework, starting with the Digital Health Act, which has spawned the creation of the Digital Health Act, the Social Health Act, the Primary Health Act, under which we are now community stands. And then we have also the complementary laws that have also facilitated all this. Us being able to look at how we're going to achieve this mission, the MOH vision of implementing a comprehensive integrated digital health information system. So this is the work that began a lot of these conversations, and this is the general architecture of how the national DPI is. I can link this, maybe Job can mention this towards the end, but as you can see, ICHIS is highlighted as one of the national point of care systems to take care of level 1. For context, in Kenya, level 1 is described also as Afya Nyumbani. Afya Nyumbani is a Kiswahili term which means good health at home. So this is where now the community platform falls. And the way the country is structured, we have, as you can see on the diagram on the right, we have our community health level, which happens to be the level 1. And then we have spokes which come and connect now to the facilities. These are the dispensaries and the healthcare facilities, all of which come and link to the sub-county referral hospitals, which then have linkages now to the higher facilities like the level 5 and the national teaching hospitals. So this is the model which is being used to digitize. And this is where now the Kenya community health system comes in, where we have around 107,000 community healthcare workers who together are able to cover around one community health unit has around 1,000 households, which comes to around 5,000 people. So in one CHU, one CHU has around 10 CHPs, 10 community health promoters who are able to serve around 100 households. So this was a challenge of digitizing all this to ensure that all those households are able to receive good care at home. And this is anchored on the community health strategy for Kenya for 2020 to 2025, which has just concluded successfully, for us to be able to increase availability, quality, demand, and utilization of data at the community system. So this was just basically the overviews of ICHIS, but I won't spend too much time here because I want to talk about part of the important parts of the journey that have really gotten us here. For example, like the establishing of the Ministry of Health-led multi-stakeholder structure. This is the steering committee, which was able to look at all the different pillars that were there. The important part of this part of the important work done by this team was the assessment of what type of community health tools were available in the country, which ones were being used community. We were able to identify around over 70 different tools which were being used. And after a rigid assessment, CHT was identified as the one which was going to be used, and all the stakeholders came together and agreed that they are all going to back this. This is where now the leadership, under the leadership of the country, we were able to start early pilots. Pilots were done in counties in terms of seeing how ready we were for scale. This is around also the time where the Minister of Health, led by Dr. Maureen and her team in the Division of Community Health, were able to do the investment case for community health, where we found that for every dollar that was invested in community, we are getting $16 back. And this is part of the tools that were used to convince government that this is something we should look at to see how we can be able to scale it and take it to where it was. So this is a journey that went up, planning, seeing how to integrate with the HIE and seeing how the different catalytic investments were going to be done. So a lot of this work ended up being securing devices and testing them, doing the infrastructure setup and app enhancements that will be discussed by my colleagues. The planning of the training across the whole country, because all this scale up was done in a very short time. We had a very long planning period and a very short targeted implementation period of around, it was around 9 months of hitting the ground to get the devices and the ICHIS app across all 100,000 CHPs, and then also deciding how we're going to be able to do the reporting and the visualization and ensuring that the data doesn't sit in data centers, but it goes back to the healthcare workers who need them. So as you can see, the national target was to hit 47 counties And this is a target that was hit. Kenya has 47 counties, so all the counties were hit. And of late, we've hit around 9.06 million households. So that translates, if a household in Kenya has around 4.7 people, that's times 5, so that's around 45 million records already served. So I can hand over to Derick to take us through the app conversation.
Thanks, Ryan. So the ECHI is the Electronic Community Health Information System, and is currently powered by the Community Health Toolkit, a technology that MEDIC developed over a decade ago, and now whose technical direction and vision is guided by a strong community. The ECHIS is targeted at community health promoters and their supervisors at the community level. And then at the sub-county and county level, we have sub-county and county focal people who have some limited access to the app itself and also a lot of dashboards so that they're able to evaluate the level of activity that is happening in their catchment areas. Once this data is collected, it will end up at the National Data Center, aggregated and visualized in dashboards, and also exported into DHIS2 to fit the standard MOH reporting tools. This ensures that there is visibility at all levels, from the CHP, sub-county, and the national government, county and national government. So the goal of ECHIS is to optimize service delivery for the Ministry of Health. The goal was to digitize all service areas that are under the mandate of the CHP. So currently, assessments for both under 5 and over 5, immunizations, pregnancies, family planning, referrals, commodity management, and you can see meeting and death reporting for vital statistics, economic survey to understand the economic level of each individual. Each is now being used as a source of data to evaluate what level of premium an individual is able to afford for the national health insurance. It's very flexible. These are just a limited number of areas we've surfaced here, but it can be customized to fit different use cases. So, and the technical features under consideration during the assessment, things that were highlighted include being open source, being offline fast, because we understand Kenya is very huge. Not all areas are connected to power or internet, and the app should continue working and not hinder service delivery. Use of open standards. The CHT makes use of a lot of tools within the ODK ecosystem, which means the knowledge acquired using tools such as ODK or COBO is easily transferable. Interoperability to ensure that the community health data can be exchanged with facility systems, also national reporting systems, and configurable. So the CHT during the assessment had demonstrated that it was possible to digitize most, if not all, of the service areas that were under the mandate of the CHP. So this is a different presentation of the service areas and features that the CHT and in turn ECHIS supports for the health system in Kenya. So you can see the 3 levels: the community level, sub-national level, and national level. At the community level, the CHP registers the households, the entire catchment area, support service delivery based on the areas I've mentioned, and also refer patients to the facility. At their level, they also have dashboards at the phone to ensure that they're able to keep track of their performance metrics. At the subnational level, we have supervision, which is the main job of their supervisors and also the county and sub-county focal persons. So there are supervision workflows and also supervision dashboards to help them target support where it's needed the most. We also have surveillance and then data quality and validation checks at that level. Supervisors also communicate a lot with their community health workers, and there are some messaging features within the CHT to support that. At national level is where everything comes together. Linkage to national systems, these registries, client registry, health worker registry, national reporting tools like DHIS2, dashboards for performance management or just getting a sense of how the health system is performing. So the dashboards that are exposed to ministry even the presidency, having visibility on surveillance metrics and such. So this is but an illustration of user experience of the CHT on a mobile phone in the hands of community health worker. So typically log in, you land on a tasks page that shows you what follow-ups are due today. And you log in, look at your follow-up tasks. From there, you can action. So you just click on it, opens up a form, you get to do your work. You can also register households. You can render your services and then look at your performance. We'd be happy to follow up with some recordings of this experience for further consumption. I'll hand over to Job.
So thanks a lot, Derick and Brian. First, I want to, thank Ehin for this opportunity. We learn a lot from Ehin and how active you are, and it's quite an honor to be part of this. So I'm Dr. Job Nyangena. I work for Safaricom PLC, which is the largest telecommunications company in East and Central Africa. We've done very well in the telecommunications space, and we are now trying to pivot into other technology areas as we seek to become a purpose-led technology company by the year 2030. And so this means we look into other areas where our scale can support and be an area of growth. So how does Safaricom enable EGs to scale? First, we provided nationwide connectivity. So Safaricom has connectivity 4G and 5G across the country. And we provided, so first we got, the government contracted us to get devices. We have an assembly plant for mobile devices in the country. So we got mobile phones for all 107,000 community health promoters. Then we connected them to our network, which is the best and has the widest coverage in Kenya. And then we hosted the EG's infrastructure. We provided cloud infrastructure and support services for that. And security and support for analytics. But now for interoperability, that's where we're getting into right now. And I'll discuss this in the last slide. So what we provided was one, mobile devices. So we have 107,000 community health promoters, CHPs. And so each of them has a mobile device that was procured from our local assembly plant here in Kenya. Then we provided a connectivity package that is mobile data. Then we provided a platform for mobile payments to the community health promoters. So the reason they're not called community health volunteers in Kenya is they get a small stipend every month. And this stipend is sent to them over our mobile money platform called M-Pesa, one of the first mobile money platforms in the world. And then we're supporting disaster recovery data center services on our Safaricom cloud. Then we provide a toll-free service for support at the Ministry of Health. And we have a mobile device management service where you can do updates and control the mobile device remotely in case the CHP is having issues, and you can support them remotely. And so all this is on a platform, an infrastructure platform of connectivity, of cloud hosting, cybersecurity, and the devices. So this is really a new way of how telecommunication companies, which have scale in terms of connectivity and technology infrastructure, can support healthcare to move beyond the pilot stages or the small implementations to national-wide implementations, because health partners, ministers of health, do not have this capacity, especially from the technology infrastructure perspective. And so with this partnership between Safaricom and the Ministry of Health, we have shown that it is possible to have a fruitful partnership with the telco industry in any country, because in any country, the telco has the highest, or rather the widest network in terms of connectivity. They have the highest experience in terms of technology infrastructure. And so these partnerships, I think, can prove fruitful to support healthcare in terms of scaling up. because I feel like most countries are moving away from pilot implementations, from vertical integrations to wide-scale, holistic health ecosystem-wide implementations of digitization. And so seeking partners like a telecommunications company, I think, would help in that sense. So we are setting up the digital health superhighway. Ryan showed this slide earlier, and it's basically a health information exchange that supports data flowing seamlessly across the ecosystem. And we've set up, Safaricom was contracted after the ICHIS program to work on this digital health superhighway. So we are part of a consortium that is delivering this for the government. And so remember, ICHIS is in level 1, and level 1 in Kenya is the community level. And then level 2 is a dispensary, level 3 is a health center, level 4 is a district hospital, level 5 is a county referral hospital, and level 6 is a national hospital. So we want to connect health information to flow from level 1, which is ICHIS, to level 6, which is tertiary level facility. But also, we will have personal health records, so we'll allow patients to have, data and their own data on a mobile app. So what are we doing to support integration of ICHIS into the superhighway, the digital health superhighway? So technically, there's the architecture considerations and the standards considerations where, we have to resource, do the fire resources or the fire profiles properly based on the, user personas that are working on, in the community ecosystem. We have to map the data and harmonize it across community and the clinical world. We have to set up the API gateways, so the interoperability layer that does a lot of orchestration. We have to map that to the ICHIS workflows. And then we test the different 1 or 2 use cases first to see how well this integration is working. And then from a governance perspective, make sure that we are aligning to the data governance regulatory framework in the country with data sharing, master data management, community health workers facilities in the country, and the clients themselves. So we can have further discussions on this, but this is a high level view of how we are supporting ICHIS, or rather how we supported ICHIS to have national scale, and how we're supporting them now to with the interoperability work in the digital health superhighway.
Thank you very much, Dr. Job. I think before we hand it back to the AHIN team, maybe one thing I can add is one of the things that has come out from this work is the importance of the partnerships and the importance of Ministry of Health having a very clear strategy for how we are going to get to where we're going, because I can promise you at the start, we used to hypothesize that digitization begins at the facilities and then trickles down to the community. But after the partnerships formed and the work was done, what we've discovered is actually a good ICHIS implementation is actually a very strong proof of concept for national-wide digitization, and that has been the story. So even the collaboration between the telco and the Ministry of Health began with the community project, and then it grew into the national project, and now you can see the national project is now feeding back to support ICHIS because ICHIS has gone through its scale, maintain, improve kind of cycle. So the ecosystem is growing and ICHIS is now entering into the sustainability model. So thank you very much. I hand it back.
Thank you, Dr. Ryan. I would like to invite Ms. Bala Rai from the Asia team. Thank you.
Yeah, thank you. Namaste, everyone. It is out, I'm so overwhelmed to be a part of this webinar, and I want to thank the organizing team and also the team Africa, Dr. Ryan, Derick, and Dr. Job for your wonderful presentation. And listening through your presentation, I could relate many of the activities and the way you have been implementing the community health program in your country as well. So I would like to thank you all, and then for the wonderful presentation, and to share my presentation with you, what we have been doing in our country. I have Dr. Nitin and Prajwol and Bishan from Nepal team as well to support me throughout this presentation. And if you have Any additional queries, please let us know. Yeah. So, oops. So, sorry. So this is the first slide, and then to highlight with the picture we have here, there is a community health nurse who is been working in the tab with the community health information system that we have been developed, and then we have been implementing this program. So our program is like community health nurse led longitudinal community based intervention. To open the presentation, I would like just highlight this slide where we can see our program is based on the longitudinal care. This starts from the preconception till the adulthood and then the geriatrics also. So throughout, like it's a continuum of care which we focus in this community health program. Now, just why we need this program, just to add on in this slide, as you all know that the disease burden is increasing, the NCD is there, you can see just the tip of the iceberg is there, and then there are a lot of more percentage of the disease burden is there which is still hidden, and just you can see the hypertension prevalence and then diabetes prevalence as well. Similarly, talking about the maternal child health also, these all are the data of the Demographic Health Survey 2022 of Nepal. You can see still we are struggling in institutional delivery. In health facility, we are a target of achieving 70 per 1 lakh live births, but we are 151 right now. And maternal deaths, but yet we have the highest number, but also they could be preventable. 60 to 8 to 70% could be preventable, and the common deaths includes one of the or more 3 delays, which is 70%. And also talking about the demographic and urban shift, we Nepal also is facing the same issue that other countries have regarding the aging population, which is growing annually, and then the urban lifestyles, and also there is a increase in the highest of the chronic comorbid conditions also. So keeping these things in the background, and the demographic structure which is being changes, and then there are some disease burden changes, and also the community expectation, what we see is that in the facility based system, these all things are being missed. Some of the things are being missed, as we have a tendency that when unless and until we have the severe problem, we don't go to the hospitals or the health facilities, and there are some fears, and they have then a late presentation. So now to tackle this, only few of the people or the population having issues or having some serious conditions visits health facilities. So the health seeking behavior is still a challenge in our country. So, and most of the disease burden and the issues are still in the community. That's why this program focus on the community health intervention and door-to-door program. From the government side, how our program is supported are the mandates that we have been provided. We have our constitutions, we have our roadmap, which has Nepal Safe Motherhood and Newborn Roadmap, and then we have our national health policies, and we also have followed the WHO guideline, which also have the framework for the community health program. So all of these mandates have given us, a kind of direction, a kind of legal mandate to design this program and to move forward. Similarly, now to discuss about the community health program, how we are running it. The main program objective, the first one, very important, and I think this is the important objectives because we need data for the planning for coming year, how to invest in the health, and how we can decrease the out-of-pocket expenditure. So the first objectives, maintaining the individual and family level digital health records is very much important. So the objectives is to create a health profile, to integrate the community-based health services in the community level, as we have different kind of vertical programs which have been implemented in the community, like TB program, HIV and malaria, and then motherhood, safe motherhood, and different. So what we have designed in this program, the program objectives also keeps a vision to integrate all of the community health services, providing at the local health level. And beside that, we also focus on promoting the healthy lifestyles and disease prevention, focusing on the NCDs and also the communicable disease as well. So as in the first slide, I have shared you that there is continuum of care. The longitudinal care model is here in the community health program. So it provides a life course based screening from the preconception to the geriatric or the senior citizen also. And then we focus on the screening, health promotion, and the basic care for all of the population group from preconception to the geriatric or the senior citizens too. And I think the one objectives is also one the early identification of the priority disease conditions and referring it basically the NCDs, mental health, and the common cancers. And BCC is very much important. This is also one of the major objectives where we have been focusing our program, like focusing on the behavior change communication, which may be enrolling in the health insurance schemes or like health seeking behavior, lifestyle modifications. These are the things that we have been doing. And now in this program, I think we are the few of the countries where I think we have mobilized the community health nurses for the community health program. So now who are the nurses or who are the community health workers in our program? They are the formally trained nurses having the 3 years academic course. They are full-time, they are salaried, and they are supervised by community health officers. So we have that modality where we have one community health nurse per one ward, and then to supervise all of the community health nurses, we have a community health officer who provides on-site coaching and mentoring and also monitors their work. So what they do, definitely when we say the community health workers, they provide a longitudinal care using a life course approach and a universal population coverage. UHC is one of the key core components of this program, providing all the integrated service from birth to the senior or the adulthood. And we also coordinate with the local health facilities and also with the community health volunteers, as Nepal has been always recognized as the country having the female community health volunteers since a long time. We also, this program, and then our community health nurses and workers also coordinate with the female community health volunteers through this program also. So how, and I think this is very important, and then the webinar which focuses on the digital platform health, and this is our strength of our program. Our program is totally paperless, and then we have this application ECHIS, and that is taken from the built from the open source CST toolkit. And this is I think this system helps us to do whatever the activities we have just discussed, like having the household profile creating, and then visiting, scheduling, and and everything. I think whatever our community health nurses are doing, they are doing through these applications. So now just to highlight how our program governance, how it's being run, how the implementing model is being done. So as we have free level government, and from the federal government, under the leadership of NSST, which is Nursing and Social Security Division, we have implemented this program in 5 of the municipalities right now. And we provide standards, we develop guidelines, and similarly, we also closely work with the local government as well. And then we have, we prepare, or we draft, we develop the standards, the policies, and other kind of any leadership or the policy leadership that we need. And we have decentralized the implementation to the local level, and they have been operating this program through the municipalities, and they are supervising this program. And also, as I found in the African team also, you also have technical working committee and then steering committee as well. So similar in our country also, we do have a federal level technical working committee where we discuss on how to move on and if there's any issues regarding the budget. So this is the way how we are keeping in check, and then the governance and then maybe the budget, everything has been done in that. And I think there are main three as we have come to 5 years of this implementation, there are three sustainability pillars here in our program, which is, I think, cost sharing financial model. Here the federal government invest few of the amount, and then the local government also invest. So it's a co-financing model, and that has also been one of the pillars to make this program sustainable. And we have this government-owned digital infrastructure, as we mentioned. It is community health information system, and the cloud is in our government server, and it has been owned by our Nepal government. And I think that is also one of the pillars for sustainability of this program. And also aside, having the program being implemented as a pilot, we also have been conducting implemented research along with the program. So the data, the evidence that has been brought up by this implemented research has also gave us idea or the evidence that we can scale up the program. We need more investment, and given a strong evidence to continue this program as well. So when our program, when we initially start this program, we had the 2 phase of programs. In the first phase, we are doing a foundation and profiling, where our community health nurses go to door-to-door services. As I mentioned, one ward, one community health nurse is been recruited, and she does all of the registration and plating and household the plating and registration. And every individual of the house has a profile, even the rented one also. We select, we name it as a unit of as a household also. So they go to door, and they create a profiling. And in the second phase, now when we complete the household survey, when we have the data, we have the health profile of every individual present in the population, we start the care delivery. And the care delivery is life cycle based care delivery, starting from the preconception and to the till the tomb. And also we also have a bridging between the health facility and the community. So that is also done in this program, where we integrate the community and also the healthcare delivery system in the municipality, or maybe in the province, or in the federal level. And during this period of time, or during the phase of delivery also, there is a continuous surveillance and continued recording also, and what kind of services they are providing. And we also do a real-time monitoring, field planning, and supportive supervision through the application as well. So now how we are tracking the universal health coverage services. The first one, as I told you, the family profiling, the socio-demographic information. We also have the vital statistics and the RMN services, which include this of like FPANC, delivery and postnatal care, and NCD. We more focus on NCD as well. We do a hypertension screening, diabetes screening, cervical breast cancer screening, and also we have neonatal and child health, and we also have the infectious disease and epidemics as well. And now we are planning for the digital payment also. This is it's in the planning, the digital plan, the payment and the stock management. Yet it has not been rolled out through this system, but what we are thinking, making it more professionalized and making it more transparent. We are planning for a stock management also, as they have been provided with few of the medicine and supplies. I think stock management is very much important, so we are planning for that. And then also for the payment, digital payment for the community health workers as well. So these two are in our plan. And just to share you how just a use case of our minutious longitudinal care, when a community health nurse visits a home and there is a women with a reported age group, she conducts a pregnancy screening, postpartum contraception counseling, and if there's a pregnant women, there is an ANC checkup, and if she's pregnant, and then the postpartum, there is a PNC care, high risk screening, and also referral to the health facility. So this is how our community health nurses are working, and it also has this under 5 child where we follow the CBNC guideline based on the under 5 care screening and counseling. So and this is the things what we do in the community. So and sorry ultimately, if they are have any kind of high risk client, a mother or a child found in the community, it is referred to the health facilities. So this is how there is a chain of care, starting from the pregnancy screening and providing care, follow up in the PNC, child care, and also referral and follow up to the health facilities. And this is what I think you all may have been the main thing that we are discussing today, just to share you how we are working. So the concept I have shared is the delivery of care and what they are doing, how we are tracking it, and this is all done by the community health information system. Just to give you a snapshot of few of the features of our app, where basically you have a luxury profile for patient-centered care, and then you have a care guide. I think this care guide is very much important for and helpful to our nurses as well, maybe to make a decision regarding the NCT screening or the ANC or the pregnancy. This app has that feature which provides the support to give a decision or to provide the care. What next? If you find a mental health patient, or you have any suspect regarding the suicidal risks, what to do next? So I think that is inbuilt in these applications, which provides the community health worker to provide a guide to decide what to do, like when to refer, when to for example, the danger signs regarding the ANC, the danger sign to PNC. So this is also our features, and all of the tasks are scheduled, in the system. So whenever I meet a client, and if I meet a client who is pregnant and following the 8 protocol visit, the application gives me a reminder. Okay, now Miss Bala is visit is going to be happened, and or you have to visit her. So that's a task reminder. It notifies to the community health nurses, and also if she doesn't fulfill it, then it is also being reported to the community health officer as well. So the community health officer, who has been monitoring and supervising the community health nurses and their work, the notification also gives alarms to the community health worker. And this is I think strength, or the main important point, how the work is being done, collaborating with the digital system, the care delivery model. This application helps our community health nurses to remind and visit and to decide what to do. And also now we have a dashboard regarding the indicators according to the municipality, what indicators they are more focused to, the prioritized indicator. It is in the dashboard. So all the data, all the services that has been provided by our community health nurses in the community is being displayed in the dashboard. And also we have that messaging and the rapid communication facilities and in this app also. Now, regarding how the user's role and the hierarchy, starting from our federal government, which is Department of Health Services, and then the district, the municipality, the ward level, the house level, and the house level, and the nurses as well. So here we have identify who is the users and what are the roles they have been assigned to, like the health focal person, supervisor. They have a analytic dashboard. We also have a nursing and social security division. So from the analytic dashboard, they can evaluate and they can see the daily progress and the data, the indicator they want to focus on. from this program, and they can plan for the coming year as well, like in the coming fiscal year, what needs to be done, what health programs should be intervened, what is the status, what investment is needed in the municipality. So programmatic feedback is also observed on the analytics dashboard, as well as we from the federal government also can view all of the analytic dashboard, and we can see how the progress is going, how federal government needs to refine the policies, make the standards, and move forward. And also the CHO, I think they are the immediate supervisor of the community health nurses, and they also have this analytic dashboard and supervisor app. Now they will the progress, they will look on the progress, they will provide the feedback, and then also they will also supervise the community health nurses as well, and they will remind, and then if there's any kind of issues, they will report back and follow up. So this is the way how they are doing community health officers. And then community health nurses, who are the users who are going to the house with this application. They now we are using a tablet, and they have this app, and they are now giving the service. They are starting from the household profiling from each of the houses, leaving no one behind, including all of them. And then according to that, the age group, the forms, the tasks are generated, and they are filling the tasks, they are providing the care, they are referring, they are screening. So all of the things that they are doing, and for daily care delivery, they are recording, and they are also reporting. So now the program, if it just to share you the results of, as I mentioned, one of our sustainability pillar to generate this to evidence for the longevity of this program, we have implemented research being done focusing on a MNSCH component. We are also doing with the mental health and NCT as well, but I think MNSCH component has been the research has been completed, and we have the data right now to share you regarding the institutional birth rate. So this is of one of the municipality, only one of the municipality where this program has been implemented, and then you can see the trend where the institutional birth rate is been increasing from the year the baseline till the year third. So this is also one of the, I think, the evidence which supports that yes, this model is very important, and we can achieve the SDG what we have set, and decrease the maternal mortality in our country as well. And I think in our country, Nepal, we have been always struggling regarding the postnatal visit. The postnatal visit is never, being completed or having more than 80% in any of the DHS data. So this is also one of the challenge, because when once a mother and child is been discharged from the hospital, and when they go back home, the follow-up and the health worker going to the house is very much limited due to different factors as well. I think from this program, what we can see is that the postnatal care at home has been increased. You can see from the baseline to the year third. Now, from the CHN pilot, what we have found is it's proven and mature, and there's an ability to scale up with a high service coverage and affordable as well. We also did a costing analysis of this program through the implementation research, and here is the costing findings, where you can see US dollar 0.74, which is an NPR 107 per capita, and it's very much modest and to similar program in LMS setting, which give evidence that we can scale up in our future. Because it only requires 3% of the local budget, as WHO has mentioned that you need to have 10% of budget in health. So 3% is very much, I think, modest cost for us, but it doesn't require more massive kind of new revenue streams. And in the invest in the community, you can see cost is in the more than 80% is community health workers and the services. Now, moving forward to the way forward, what our federal government and government of Nepal is planning to is scale up this program and institutionalize further. Especially, we will be focusing on the co-financing model, where few percentage of investment is from the local level, and we wanted to now add this provincial level as well. So it's a kind of 3-tier engaging in the same and having the co-financing and model. and more focusing on the high burden and underserved areas. We want to integrate with the primary healthcare delivery, more preventive and follow-up care, similarly through all of the level of health services, adopt the life core services. So yes, the another one is interoperability, and then yes, we do have a national information system for health also, which is SMS, and we also use the DSS platform as well. And we are been when we have started this program, we are on the same discussion with the HMS and looking for of the interoperability and the digital readiness. So we have like open APIs, interoperable systems for and securing data system, and also streamlined partner onboarding. So yes, thank you for listening me. These are the things that we have been sharing. I think it's a short time to set out. We have done a lot of things, but it's a very short time to share. I hope it was very interesting to know for you also. And if any additional queries from your side, we are ready to respond it. And our team, the technical team, is there. Thank you so much.
Thank you, Ms. Bala Rai. I think both the presentations from both the teams have been very, very detailed and very interesting. It's just that we are at the top of the hour. I know some questions have been there and some of which have been answered. Maybe if there are some questions which are still yet to be answered, maybe we can take one or two before we wrap up. And then also I know there are two other speakers. Nitin and Prajwal, do you have anything quick to say? I know you have not spoken.
Thank you, Jay. I think Ms. Bala Rai has explained everything. No more addition from my end at the moment. Happy to answer any questions offline later on. Thank you so much for the opportunity.
Thank you, Nitin. I know both the teams have been very shared the workflow, the governance, and then various things very in detail. But if there are similarities, of course, and then there are, especially if there are differences in which, because each countries and then there are priorities, and there could be differences in terms of how it is implemented or administered. So if that can be brought out, I think that's also very interesting for the participants to know. Thank you.
Thank you. From the presentation I've seen, I was actually very, very impressed by how well I think Medic has done, because as there's a lot of similarity between CHT, the CHT we were seeing there between the two implementations that we were seeing. I'm also very, as the previous speaker pointed out, in terms of governance structure, there were very great similarities. And that is where a lot of the similarities are anchored. Because if at governance level you have similarity, then some of the decisions that you do going down as you go down are not going to be reinvention of the wheels. So in terms of the longitudinal approach, that is very similar. In terms of the mobile and tablets, that was also very similar. I'm very impressed with how the data is going back to the CHNs. In the presentation, that is something you can really learn from the teams in terms of how to enable them to be able to own the data, not just to collect it. That was a big win that we've seen. That is something we can also learn. Maybe also Derick can give a comment, but there were a lot of similarities, and I'm very encouraged to see that.
Thank you, Dr. Nitin.
May I? Sure. Yeah. Just to quickly add that I think that it's been a great learning experience, especially for us who are like few steps behind what Kenya has been able to achieve. And I think there are a lot of things that we still need to do in terms of digital public infrastructure, and that is something that we are working with the Ministry of Health and the technical team to come up with a more robust system. Just to give you a more update. Thanks, and we'll be following the Kenya team more for the details.
Thank you, Nitin. So maybe with this, I would like to actually bring this webinar to a close, and Cha, over to you for the wrap up and perhaps a group photograph before we call it a day.
Yes, thank you so much, Sir Joy, for moderating the session, and to our speakers from both the Asia and Africa teams for sharing your work with the Asian community. All right. Thank you, everyone.
Thank
Have
you.
a good day and
Get in
night.
touch.
you.
Thank
Thank
you.
you. Bye.
Thank you. Thank you very much.
Bye-bye.
Thank you all. Thank you.